Yes. So we're going to continue our case discussion for the Mrcp consultation station, and today I'm going to talk a bit about non-alcoholic fatty liver disease. So as usual, let's start with the history. So this is a 56-year-old obese male and is referred to hepatologist following multiple blood tests showing liver enzyme derangement. He is otherwise asymptomatic except for lethargy. Now, remember the peak prevalence of non-alcoholic fatty liver disease in men and women is noted to be between 50 and 60 years of age, with the general trend of increasing prevalence with age. And gender difference exists with pre-menopausal women at a reduced risk of non-alcoholic fatty liver disease compared with men. After menopause, there is comparable prevalence of NAFLD in men and women. It leads many researchers to think that this protective effect of estrogen in the premenopausal woman. So it is estimated that 1 in 4 individual has non-alcoholic fatty liver disease, with many unaware due to asymptomatic nature of the disease. So non-alcoholic fatty liver disease and NASH, which is non-alcoholic steatohepatitis, these are the most common causes of chronic liver enzyme derangement. And you can see ALT may be high, AST and gamma GT also high. In the absence of any causative agents such as hepatotoxin, viruses or genetic disorders that affect the liver, further investigations and referral to hepatologists are warranted. Okay, let's move on to our history. He is otherwise asymptomatic except for lethargy. His past medical history is significant for hypertension, hypercholesterolemia, and type 2 diabetes mellitus. So obviously in your history going to ask about the past history as well. So most patients with NAFLD are asymptomatic, and it is often an incidental finding in patients who are being reviewed for other metabolic diseases like diabetes mellitus, hypertension, and hyperlipidemia. So the NAFLD actually exists as a spectrum, which is most severe from being NASH until its conversion to NASH or cirrhosis. Fatigue is the most common complaint. Very rarely, patients have symptoms such as stigmata of liver disease like pulmonary edema, hepatic flap, or spartaneva, or symptoms of decompensation, which include jaundice, ascites, edema, GI bleed, and encephalopathy. But remember that fatigue, especially in this patient, may be related to obstructive sleep apnea, which is extremely common in obese patients. Okay, and I'll talk a bit about the metabolic syndrome. So metabolic syndrome is a cluster of disease that increases the risk of cardiovascular disease, stroke, and diabetes mellitus. And patient must have at least 3 of the 5 medical conditions. These are central obesity, hypertension, impaired glucose tolerance, elevated triglycerides, and low level of HDL. And NAFLD is considered the hepatic manifestation of the metabolic syndrome. Insulin resistance promotes adipose tissue lipolysis, so allowing the free fatty acids to deposit in the liver, and these leading to steatosis. Okay. Patient has poor medical compliance but has been prescribed multiple medication, and he also remember receiving some vaccinations to protect his liver a few years ago. So apart from non-alcoholic fatty liver disease, NASH, other common causes of chronic liver disease include alcoholism and viral hepatitis. You know this hepatitis B virus and hepatitis C virus. And hepatitis B is a vaccine preventable disease. Coming to the family history, patient family history is significant for metabolic syndrome, but there is no genetic disorder. So family history actually plays an important role for the development of NAFLD and NASH. So there is evidence demonstrating strong heritability for this disease and its associated comorbidities such as type 2 diabetes mellitus. Its inheritance pattern is unknown, but several genes as well as environmental factors, these are implicated in its pathogenesis. And genetic diseases such as hemochromatosis and alpha-1 antitrypsin deficiency, these can also cause hepatic injury. So while you're taking the history, it's important to ask about any genetic disease in the family. Okay, let's move on. Our nutritional history reveals poor dietary choices with fast food consumed daily. Now, poor dietary intake is one of the main, I can say, perpetrators in the pathogenesis of NAFLD or NASH. Common foods in the Western diet like processed sugars and fat, refined grains, soft drinks, they can cause rapidly increases the postprandial plasma glucose and insulin level. And this leads to increased de novo lipogenesis, one of the main contributor to hepatic steatosis. Okay, let's move on to our history. There is a lack of fresh fruit and vegetables in his diet, and he consumed large quantities of soft drink daily. So if you are suspecting a patient having this non-alcoholic fatty liver disease, it is important to dig a bit more about the patient dietary habits. So there are numerous animal models of NAFLD and NASH, and these have shown the importance of fructose in the pathogenesis of this disease. And fructose has been demonstrated to promote de novo lipogenesis in the liver, resulting in hepatic steatosis. It also induces oxidative stress, which is a necessary step to initiate hepatic inflammation and impair normal hepatic fatty acid oxidation. The mechanism through which fructose and NAFLD are linked are complex, but its association is well established. Okay, he does not drink alcohol, smoke, or use an IV drug. So alcohol history is very, very important because alcohol remains one of the leading cause of chronic liver disease in the developed world. Its mechanism of injury is complex and multifactorial. Like NAFLD, chronic alcohol consumption can also cause hepatic steatosis and chronic liver injury. So when ethanol is enzymatically broken down, it forms acetaldehyde, which is a direct hepatotoxin. And it is toxic to mitochondria and the hepatocytes, causing oxidative stress and promoting cell death. And another important point is the metabolism of alcohol also induces the production of NADH, which is a cofactor that promotes steatosis by stimulating the synthesis of fatty acids and opposing their oxidation. And must ask about any history of any IV drug use. Why it is important? Because several strains of viral hepatitis These can also cause chronic liver disease like hepatitis B virus and hepatitis C virus. Hepatitis B virus is highly infectious and can be spread through sexual contact, sharing of needles, improperly screened blood transfusion, and mother to child transmission. Hepatitis C virus is actually primarily a blood-borne virus and spread through blood-to-blood contact. IV drug use is the most common form of transmission in the developed world, and it is important to screen for these infections while we are taking a history. He rarely engages in physical activity and has a sedentary lifestyle. So lifestyle must be mentioned in your history. Sedentary lifestyle is defined as lengthy periods of inactivity and minimal movement, such as in television watching, sleeping, or sitting. Sitting for prolonged periods reduces cumulative energy expenditure produced by muscle contractions during movement and impairs the exercise muscle contraction stimulated uptake of glucose from the circulation and lipoprotein lipase activity. So thus hampering the fat handling. This can compound the detrimental effect caused by a lack of exercise, leading to increased risk of NAFLD and NASH. So that's all about the history. I think I have give a detailed account of the history. Now let's talk about the examination. So the patient is morbidly obese and weighs 230 kg. He is calm, alert, and oriented to time and place, but is slightly tachypnic. So obesity, objectively it is defined using BMI, but several studies note the importance of fat distribution in the development of metabolic syndrome. So notably, truncal or central obesity has been strongly implicated in the development of other cardiovascular and metabolic diseases. As an estimation, 90% of morbidly obese patients have NAFLD. So when patients with NASH cirrhosis decompensate, they can present with complications of portal hypertension like varices or ascites. Hepatic encephalopathy is also a hallmark feature. It's caused by accumulation of nitrogen compounds in the brain secondary to impaired hepatic clearance, and this causes confusion and impaired memory and concentration. So obese individuals actually tend to have a rapid shallow breathing pattern, predominantly due to mechanical factors. So there is a reduction in respiratory compliance due to increased weight on the thoracic cage and abdomen and associated with accumulation of fat. And severe obesity, it can actually lead to obesity, hypoventilation syndrome, and sleep apnea overlap with decreased responsiveness to oxygen and carbon dioxide, accompanied by alteration in respiratory muscle function. Okay. Apart from some mild hypertension, he is hemodynamically stable and afebrile. Peripheral examination reveals palmar edema and some darkened patches of skin in the axilla, but otherwise unremarkable. Now, palmar edemas, these are associated with chronic liver disease such as NAFLD and NASH. So, as the damaged liver is unable to metabolize ostradiol, this accumulates in the blood and causing increased vascularization of surface hand capillaries. The darkened patches in the axilla, these are actually acanthosis nigricans, and this is a dermatological condition which is characterized by hyperpigmentation and hyperkeratosis of skin, particularly in the skin folds such as the groin, back of the neck, and axilla. And it's related to insulin resistance with increased circulating insulin activating receptor responsible for keratinocytes and dermal fibroblast proliferation. Okay. Hepatic flap and scleral jaundice are not observed. Hepatic flap can be indicative of hepatic encephalopathy. The damaged liver is unable to break down toxic ammonia into urea for excretion, so causing it to accumulate in the brain. It is believed this affect the diencephalic motor centers of the brain, which maintain the full extension of elbows and wrist. So elevated bilirubin can manifest clinically as scleral jaundice. In NASH, hepatocyte death reduces the liver ability to metabolize and excrete bilirubin, so leading to an accumulation of unconjugated bilirubin in the blood. Chest examination reveals gynecomastia and spider nevi, along with an increased work of breathing. Cardiac and respiratory sounds are normal. Now, the accumulation of estradiol in male patients with cirrhosis causes the development of female body characteristics, and there is proliferation of glandular tissue in the breast causing gynecomastia. And we know that this elevated estrogen level, these are thought to be responsible for some vascular lesions as well, and these are characterized by a central red spot with reddish extensions like a spider web. Pathogenesis of spider nevi is not well understood, but stems from failure of the sphincter muscles around the arterioles. And spider nevi, remember, they are also found on pregnant women. Deep abdominal palpation elicit minor right upper quadrant tenderness and hepatomegaly with a smooth liver edge. There is no other organomegaly, and bowel sounds are present and normal. So abdominal examination generally is unremarkable. Some patient may complain of right upper quadrant tenderness due to hepatomegaly, which can cause stretching of the capsule enclosing the liver parenchyma. And patients with NAFLD or NASH, they tend to have smooth and large livers due to accumulation of fat within the parenchyma. And it is extremely unusual for the liver edge to be hard or nodular unless there was cirrhosis or an underlying malignancies. So other features of hepatic decompensations, they include ascites, edema and splenomegaly, and which can cause abdominal distension. So this is all about the examination, and you can see in the examination, so we have to do the, actually in the consultation station, you need to do the whole examination, but here we'll be focusing more on the general physical examination to look for the stigmata of the liver disease, and then going to the GI examination. Of course, you're going to do briefly the cardiovascular and respiratory examination and look for signs of encephalopathy as well. Okay, let's move on to the investigations now. So investigations are like to divide into two groups, pathology and imaging. So patient full blood examination and biochemistry are normal. We'll like to do the liver function test, and we expect to see an elevated ALT, AST and gamma GT, but there are no changes in ALP. So alkaline phosphatase, if there is, they're more signifies the obstructive jaundice, so we don't expect it to be much raised. Albumin and bilirubin, these are not elevated, can be elevated. Bilirubin can be elevated as well. Fasting lipid, cholesterol, fasting cholesterol and lipids are elevated, and fasting blood sugar is deranged. So dyslipidemia is a common finding in NAFLD and NASH, and fasting blood glucose tend to be deranged, as insulin resistance is a key component of NAFLD and NASH. Hepatitis screening, iron studies and ANA antibodies, anti-nuclear antibodies, ANA, are normal. Now, remember that patients with abnormal LFTs, they should also be investigated for other etiological agents. Uh, these include alcoholexis, viral hepatitis, autoimmune liver disease, hemochromatosis, celiac disease, and Wilson's disease. Now we come to our second group, which is imaging. And as NFLD was clinically suspected, a liver ultrasound was ordered to confirm the clinical diagnosis. So, ultrasound should be the first line investigation for suspected NFLD, as it provides extensive information regarding the fatty infiltration and size and can screen for suspicious nodules. It is cheap, it is easily accessible, safe, and effective in diagnosing established steatosis. So findings normally include diffuse hyperechoic liver with increased ecotexture relative to the renal cortex or spleen due to increased fatty infiltration. And there may also be poor delineation of the intrahepatic architecture. A follow-up CT scan or MRI or liver biopsy would be considered if the ultrasound findings were not definitive. So non-contrast CT or MRI, it is not commonly used unless ultrasonography is unavailable or there is diagnostic uncertainty. Common findings include diffuse low-density hepatic parenchyma. Hepatomegaly may also be detected. And MRI has been shown to most accurately detect low levels of steatosis than those detected by ultrasound and CT. Liver biopsy is not frequently used to diagnose NAFLD, although it is still considered the gold standard diagnostic technique. And the histological spectrum of NAFLD range from simple steatosis through steatohepatitis to fibrosis and cirrhosis. And it also allows for the staging of the disease and can provide prognostic information. Okay, transient elastography could be used to measure the degree of liver fibrosis. So transient elastography, also known as fibroscan, is a relatively new and non-invasive method for assessing the liver fibrosis, and it uses ultrasound-based technology to measure the velocity and time for vibration to travel through the liver. Cirrhotic tissue is harder than normal liver due to scarring, so degree of fibrosis can be inferred from liver stiffness. Although it is not used as a diagnostic investigation, it is useful as an adjunct to assess for cirrhosis and monitor for disease progression. So that's all about the investigations. Now we move on to the management. So in NAFLD, I like to divide the management into three groups: lifestyle, medication, and surgical. So in the lifestyle, the patient are usually advised to reduce the calorie intake and seek advice from dietitian for a modified diet high in omega-3 fats, which are minimally processed, and low high fructose corn syrup. He was also encouraged to engage in physical exercise and counseled to abstain from alcohol. Coffee consumption can be encouraged because it got some protective role in liver disease. So dietitians, they play an important role in optimizing the patient health, and this treatment of NAFLD and NASH that involves a multidisciplinary team and dietitian play the most important role. They can provide nutritional guidance, develop diets to optimize weight loss, and educate patients on how to maintain long-term weight loss. And researches have shown that diets high in omega unsaturated fatty acids improve insulin sensitivity, reduces hepatic steatosis and inflammation. And dietitians also recommend a reduction in processed and high fructose products. Such foods also have been positively associated with insulin resistance and reduction in the protective hormone adiponectin. So, regarding the physical exercise, increased physical activity with exercise, it assists in the weight loss by increasing the energy expenditure, and researchers have also shown that exercise is made in the reduction of hepatic steatosis, prevent progression to cirrhosis, and improve both metabolic and cardiovascular health. And as part of minimizing ongoing liver damage, patients diagnosed with NAFLD are counseled to avoid hepatotoxins such as alcohol. Okay, let's move on to our second section, which is medications. Unfortunately, there are no specific medication for NAFLD or NASH, and vitamin E, which is actually recommended to the patient. Remember that associated comorbidities such as diabetes, hypercholesterolemia, and hypertension, they should be treated accordingly. So, high dose vitamin E actually is an antioxidant that has been shown to have some benefit in reducing inflammation in NAFLD and NASH, and vitamin E has been shown to break down lipids and exert anti-atherogenic activities. So we know that there are no direct therapies for NAFLD, but obviously other components of the metabolic syndrome should be targeted. Insulin resistance can be treated with medicines like metformin. Metformin has been shown to cause weight loss. However, it has no effect on NAFLD and NASH histology. And there has been some improvement in histological scores and liver enzymes in patients who are treated with thiazolidinediones, and however their benefit offset by their multiple side effects, and therefore they are not routinely used. So hypertension should be controlled with antihypertensive to prevent cardiovascular mortality, and dyslipidemia should be managed with statin to reduce the risk of coronary artery disease. Coming to the surgical, failing lifestyle medication, the patient would be recommended to undergo the bariatric surgery. He would also be monitored regularly due to the increased risk of complications. If he develops liver cirrhosis, he will be placed on the waiting list for liver transplantation. So, bariatric surgery is highly recommended in morbidly obese individuals who have failed an adequate exercise and diet program and suffer from obesity-related comorbid conditions. Multiple procedures are involved, and the most common being gastric banding or sleeve gastrectomy, which reduces the capacity of the stomach. Patients who develop NASH, they have increased risk of hepatocellular carcinoma, which is further compounded if there is a transition to cirrhosis. And finally, I'd like to talk a bit about liver transplantation. It remains the only cure for patients that develop cirrhosis. However, this is obviously limited by shortages in donor livers. There are multiple contraindications for liver transplant, including advanced hepatocellular carcinoma, uncontrolled viral hepatitis, and active alcohol or substance abuse. So this is all about the non-alcoholic fatty liver disease, and it's quite common case, and there's a high chance that you may come across in your consultation session. Thank you very much, and I will see you in my next presentation.